Good morning, good afternoon, everyone. Thank you so much for joining us for today's Pathology Echo. We have a brief presentation from me. I'm going to talk to you about the ATOM Coalition and the breast cancer program, WHO breast cancer program very briefly, and then Miran from St. Paul in Ethiopia with Dr. Barakat will present some interesting breast cancer cases. I apologize for the time challenge this morning. The time zone got messed up on the invite, which is a perpetual problem I'm trying to fix. But we have adjusted, so hopefully you're all there. And I see that many of you have come in, so we'll go ahead and get started. So I'm only going to talk for a few minutes, and then I will turn it over to Miran. So I wanted to take some brief time today to talk to you about the ATOM Coalition. This is the Access to Oncology Medicines Coalition. Access to cancer medicines in low and middle income countries, as you are all aware, is very challenging. There are more than 10 million people that die of cancer in 2020, and 70% of those deaths occur in low middle income countries. And WHO forecasts that the majority of cancer deaths are going to occur on LMICs in the next 10 years. So we have a big job to help you with to support our colleagues in diagnostics as well as in cancer care to reduce that burden and reduce that death. And a recent study showed that only 50% of the WHO essential medicines are available in LMIC. So this is an access problem, right? So we all talk about diagnostics and we want to make sure that we can make a diagnosis for our patients. But if there's no medications to treat them, then ultimately we're going to fail, even if we have really great pathology. So access to medicines is a key priority for WHO in the context of NCDs, but we need sustainable long-term solutions, and these are difficult to establish. So what is ATOM trying to do? So we have three pillars of work. The first is improving capacity to receive and use cancer medications in targeted LMICs. The second is making available more generic EML medicines, biosimilars, and as well as patented medicines in the third pillar through what are called voluntary licensing. So let me just give me 1 second. I just got to clear something off my screen so I can do this faster, right? And so what is ATOM? So it's an innovative partnership of nearly 40 partners that are taking collective action to improve access and capacity using life-saving medicines. And our approach for these three pillars is to develop country solutions in a sustainable and scalable way. So not just donation programs. This is a really important piece. ATOM does not do donations. What we do is try to get the cost of medications down to a local pricing structure, right? So generics to within what's available to GDP or what's available to governments so that they can purchase them. And then you'll be able to have those medications locally at an affordable price. We want to complement existing models and amplify them through innovative multi-sectoral access mechanisms. So for example, someone may be doing a donation program now. We want to transition that donation program to a very low cost system so that the medications are always available, right? If it's a donation program, there's incentives are really not there to maintain that. But if it's a model where there is a revenue stream, even though it's small, and it's benefiting the local economy, then people will continue that. And that's sort of the value that we think ATOM brings. And then we're bringing together partners from across the sectors who have all these different expertise to make sure that their track record can pull together and create a full pathway, right? So we may have someone who wants to provide a drug, but they have no expertise in how to deliver that drug. But we also have partners that are experts in delivering that drug. We have partners that are experts in diagnosis. So when we put them all together, now we have the drug available, that drug can be delivered, and the diagnosis can be made, and a patient can be treated. So these are the partners. We have 40 partners. You'll probably recognize some of these names, including Aortic, which hopefully all of you are aware of, or certainly maybe have attended. A lot of pharmaceutical companies are listed, a lot of NGOs like ASCO, ACP, BVGH that you've all worked with, and many academic partners are here as well, like the Sylvester Comprehensive Cancer Center and the UCSF Cancer Center. So how are we doing this program? So country engagement. So we've targeted 46 LMICs in the next decade, which reaches about 2.6 billion people. That we're going to start by delivering capacity development to 10 of those countries during the first 18 months. And I'll show you that list at the end. And we have a target list of essential cancer medicines for the ATOM Coalition countries, including generic and biosimilar medicines, a streamlined list of patented medicines, and I'll explain that in a second, and then pathology and diagnostic capacity support. So for these streamlined medicines, how this works is that for many of you, you may be aware that HIV medications and hepatitis C medications were brought to Africa primarily through the voluntary license program. So an organization called MPP, the Medicine Patent Pool, worked with companies who had patented medications, got a voluntary license though. So while it was still on patent, got that license, took it to a generic manufacturer, had it manufactured by a generic person at very high quality, but at a very low cost, and then redistributed that to low and middle income countries or African countries at a very much lower affordable price. And so this process of voluntary licenses allows us to take a medication that may cost $50,000 or $100,000 per year in the US and deliver that to a patient in Africa for $400 to $500. And again, we don't expect that $400 to $500 is being paid by the patient, but it's more that the government can purchase that medication at a much lower cost so they can deliver it to patients. Whereas before, when it's on patent, they really won't have the budget to do that. So the priority essential medicines list, as I said, includes generics, biosimilars, and patented meds that are on the EML. Our focus will be on those with the highest burden: breast, lung, colorectal, prostate, cervical, and childhood cancers. And our ambition is to increase access to generics. We're going to first focus on breast cancer, which is why I'm talking to you about this today, because we're going to talk about breast cancer cases afterwards, and adjuvant therapies, and then we will expand that to other medications, as I mentioned. Companies will engage their medicine portfolio by either extending their donation programs, exploring pricing options, or considering a VL pathway through MPP, which we're really excited about. And as you're all aware, the WHO program for breast cancer has been launched, and we are very closely working with and following how that program works so that all the activities and things we're doing around breast cancer are aligned with what the WHO is already putting out to teach countries how to deal with breast cancer at a systematic level. This is our operational plan. It's very straightforward. We're increasing the availability of oncology medicines to our ATOM countries. We're implementing global good public activities to bring value to the broader global cancer community. We're securing strategic partnerships to deliver the ATOM Coalition mission. We're implementing ATOM Coalition support for targeted country level building, and we're continuing development of ATOM Coalition governance and operations. So there's a lot of detail in this operational plan. I just wanted to overview it for you that way. And this is the outcomes that we expect. We expect to increase the number of essential medicines provided by ATOM to partners by the end of 2024. We expect to increase the capacity of ATOM partners to deliver donated and discounted price medications in ATOM countries of all of high quality. We expect efficient and effective operational and infrastructural solutions will be identified for our countries, and we hope that more biopharma companies will commit to provide VLs for their patented medicines, and over time, more cancer patients will have the chance to survive their diagnosis of cancer because they'll have access to medicines and diagnostics. So these are our needed inputs. So initial donation programs that can be converted to sustainable access programs. This is very important. If someone is currently donating a cancer medication, we want to convert that to a sustained program so that medication is always available and does not depend on donations. We want to increase the number of essential oncology medicines that have been PQ'd or added to the WHO CRP process, which, if you are familiar, those are two of the WHO processes for approving drugs. We want to reduce pricing for ATOM Coalition target countries of essential oncology medicines to local pricing. We want to get the drugs down to be affordable by local governments and clinics. And we need additional seed funding, but that's not for you guys. And then our proven outputs: creation of a larger market to hopefully achieve lower prices for medicine equipment in countries able to use the medicines, coordination of capacity building activities and efforts across multiple LMICs so that we can pool our resources and know how to do this in an unprecedented way, and potential support and guidance in overcoming country level registration barriers, which is another area of focus. So that is the ATOM Coalition. I just wanted to briefly go over that with you. You're going to hear more about it if you attend any meetings or if you follow any of the major organizations that are the partners. They'll be talking about it. You can follow me on Twitter and hear more about it. But we do have a lot of countries in Africa that are on our targeted list. and we'll be already started our work with them. And so many of you will be hearing about it directly as we reach out to you. But over time, we hopefully will be working with all of you as we move the program forward. All right, so let me close this. Great. So now I'm going to turn it over to Miran. That was our brief didactic. And so Miran is now going to come on, share her screen, and present some breast cancer cases from Ethiopia. Miran, are you able to share? You're still muted.
Yeah, I'm sharing the screen now.
Okay, great. And can you do the presentation mode? Yeah.
Sure. Okay. So can you see my screen?
We can, but it's not the presentation mode. It's just the slide deck mode. You'll have to switch to the presentation mode.
Okay, give me a minute.
Yeah. And if any of you have questions about Adam, or if you have questions for Miran as she does her presentation, please put them in the Q&A box, and then we will answer them towards the end. Perfect. Go ahead, Mary.
Okay. Good morning, good afternoon, everyone. I will be presenting a brief presentation about the current practice in diagnosis and management of breast carcinoma in Ethiopia. So I'll give you the brief overview of the burden of breast cancer in Ethiopia, the diagnostic modalities and treatment options that are available. And finally, I have a few cases, and I'll discuss how they were diagnosed and how they were managed. So currently in Ethiopia, breast cancer is the leading cause of cancer morbidity and mortality. It accounts for 1/3 of all cases amongst women and 1 in 5 cases of all cancer cases. According to the Globocon 2020 report, an estimated of 16,133 new breast cancer cases and 9,061 breast cancer deaths are recorded annually in the country. So here's the distribution of cancer cases amongst women in Ethiopia in 2020, and we can see that 32% of those cases are breast cancer cases. And when we compare breast incidence and mortality of breast cancer with the other common cancers, we can see that breast cancer has a very high incidence and mortality. So as a low-income country, the focus of healthcare in Ethiopia has been on combating infectious diseases. So not much attention has been given to cancer care, but given the rising number of cases, in 2016, the Ministry of Health launched the Ethiopian National Cancer Control Plan, and the goal was to reduce cancer incidence and mortality by 15% by the end of 2020. And one of those goals was to develop a diagnosis and management guideline that could be locally adopted. However, so far, we don't have any locally adopted guidelines for the diagnosis and treatment of breast cancer. And the treatment or the management plan, it depends on several factors such as infrastructure, the availability of medical personnel or multidisciplinary team, availability of diagnosis and treatment modalities, and the patient's financial status. So when we devise a management plan, we also have to consider whether the patient can afford it or not, because in Ethiopia, we do not have a national health insurance scheme. So every investigation or every management is paid for by the patient. So the financial status is also considered. So when we come to the infrastructure, currently there are 7 oncology treatment centers in Ethiopia. 2 of them are located in the capital city, Addis Ababa, St. Paul Referral Hospital and Black Line Specialized Hospital. And the remaining 5 centers are also located in urban cities. So these 7 centers are currently providing service for the entire country, which is around 115 million people. So since these centers are located in urban areas, there is a significant disparity when we look at the survival of patients who reside in rural areas versus those who live in urban areas. So according to a study published in 2023, the 2-year survival for patients with breast CA who live in rural areas with access to surgical treatment alone was 46% compared to patients who live in Addis Ababa who had access to surgery, chemotherapy, and endocrine therapy. Their 2-year survival rate was 74%. So the availability of infrastructure plays a significant role in the outcome of patients. The other factor is the multidisciplinary team. So as we know, the cancer multidisciplinary team includes health professionals from different fields like the oncologists, pathologists, radiologists, breast surgeon, and so on. So subspecialty training in Ethiopia has not been started yet. So we only have few surgical oncologists and interventional radiologists, and all of them are working in the capital city, either at Black Lion Specialized Hospital or here at St. Paul Referral Hospital. When we come to clinical oncology, the clinical oncology specialty training was started around 5 years ago. And so far, 20 clinical oncologists have graduated and 35 oncology residents are currently enrolled. There are 23 radiation oncologists who provide radiotherapy for the entire country, and 138 oncology nurses are working in the 7 oncology treatment centers. The other component is the diagnosis of breast cancer. So diagnosis here starts with history and physical examination, followed by imaging. So depending on the age of the patient, we do either bilateral mammography or bilateral breast and axillary ultrasound. CT scan is done for patients with suspicion of metastatic lesions. And most of the diagnosis of breast CA is made with fine needle aspiration. Ideally, we would want to do core needle biopsy or incisional biopsy, but since this investigative modality is not available everywhere, most of the cases are diagnosed with FNA. The other investigation that is started very recently is immunohistochemistry. So immunohistochemistry is only available in 2 cities in Ethiopia. One is here in the capital city. It's only available at a private center. And the other city is at Awasa Referral Hospital, which is a government-owned hospital. So since immunohistochemistry is rarely available and it's expensive, we do not routinely do immunohistochemistry for breast cancer. It is only done based on a clinician's demand and if the patient can afford it. When we look at treatment options, we have surgery, chemotherapy, radiation, and hormonal or endocrine therapy. Majority of breast cancer cases are treated with mastectomy with axillary dissection. If the sentinel lymph node status can be identified or can be done by frozen section diagnosis, that would be the ideal way to go. But frozen section diagnosis is only available at St. Paul Referral Hospital. So for most cases, we do modified radical mastectomy. When we come to chemotherapy, the publicly available chemotherapeutic agents for breast CA are cyclophosphamide, doxorubicin, and paclitaxel. Capecitabine is also available, but it's only available at private pharmacies. In radiotherapy is available at 2 centers in Ethiopia. One is at Black Lion Specialized Hospital, and the other is at Jimma Referral Hospital. So as you can imagine, there is a very high patient load in these 2 centers, and the average waiting time in Black Lion Specialized Hospital is around 7 months. Sometimes it could go as long as 1 year. The other treatment option is hormonal or endocrine therapy. So this management option goes hand in hand with the availability of immunohistochemistry. So if immunohistochemical stains can be done, then the available available agents are tamoxifen and anastrozole. And for HER2 positive tumors, trastuzumab is available at private pharmacies and private centers. So generally, how we devise a treatment plan for a patient presenting with a breast lump is first after history and physical examination, we do imaging, and most of the time FNA is done for the patient, and CT scan is done if there's a suspicion for metastasis. So once the diagnosis of breast CA is made and the patient is clinically staged, we categorize the patient into either curative treatment or palliative care. So patients under curative treatment would be patients with a T1 to T4 stage tumor lymph node 0 or lymph node positive, but no metastasis. So if a patient has metastasis or presents with a recurrence, then they will be categorized under palliative care. So for patients under curative treatment, we first assess if the patient is a candidate for neoadjuvant chemotherapy. So patients would be under this category would be patients with a T4 tumor, N3 positive lymph node or N2 positive lymph node if the lymph node is matted or bulky. So if a patient is candidate for neoadjuvant chemotherapy, then the regimen of choice would be cyclophosphamide and doxorubicin. So after the chemotherapy, if the treatment response is good, then we can proceed to surgery. If there's poor response or no response to chemotherapy, additional chemotherapy with or without radiation can be considered. For patients who are not a candidate for neoadjuvant chemotherapy, sentinel lymph node status is determined if the facility is available. If not, we usually do mastectomy with axillary dissection, and the immunohistochemical stains and is usually done on the excisional biopsy, and this is the specimen we receive in biopsy as well. So after the surgery, then we assess if the candidate is adjuvant chemotherapy. So patients would be a candidate for adjuvant chemotherapy are patients with a tumor larger than 1 centimeter and positive lymph node. And based on the immunohistochemical stain results, we can consider endocrine or hormonal therapy. Patients with metastasis or recurrence are categorized under the palliative care. So for this patient, we first assess the performance status. So if the performance status is good, then a full workup is done and incisional biopsy is done for immunohistochemical stains. After that, if the patient has brain or spinal metastasis, then we refer them for urgent radiation. So patients with brain or spinal metastasis are the eligible for urgent radiation, and they can bypass the waiting time. If the patient does not have brain or spinal metastasis, then we assess if the patient has taken chemotherapy before, and we can adjust the regimen based on that. And hormonal and endocrine therapy is also indicated depending on the immunohistochemical stain result. For patients with poor performance, ECOG performance 3 or 4, then we provide palliative care. So palliative care in Ethiopia is basically non-existent. The only care that we can provide at the moment is pain management and wound care. When we come to the hormonal or endocrine therapy, hormonal receptor positive tumors and HER2 positive tumors are given tamoxifen or anastrozole with Transtumab. ERPR positive cases with HER2 negative are given tamoxifen or anastrozole depending on the menopausal status. And ERPR negative cases and HER2 positive cases are given Transtumab, and triple negative cases are not given any hormonal or endocrine therapy. So this is the general management plan for patients. So I have a few cases here that I'll briefly discuss. The first case is a 41-year-old female who presented with right breast lump of 3 months duration. So for this patient, mammography was done, and the diagnosis of breast CA was made by fine needle aspiration, after which mastectomy was performed. So grossly, right mastectomy specimen was received, measuring to 23 by 19 centimeter with an ellipse of skin and intact nippleareolar complex. On cut surface, there was a well-circumscribed gray-white mass at the upper outer quadrant, measuring 1.3 by 1 centimeter. And 10 lymph nodes were also identified, the largest lymph node measuring 3 by 2.5 centimeter. So here are pictures of the microscopy. I apologize for the quality of the slide. So on microscopy, there was a partly circumscribed tumor with fascicular arrangement, consisting of moderate to highly pleomorphic cells with irregular nuclear contour, hyperchromatic nuclei, and occasional mitotic activity. And this tissue was sent for immunohistochemical stain, and estrogen receptor was negative, progesterone receptor was negative, and HER2 was negative as well. So this case was signed out as metaplastic carcinoma, staged PT1C, N1A, MX, and triple negative. So when we look at how this patient was managed, she was not a candidate for neoadjuvant chemotherapy, so she was not given that. The surgery performed was modified radical mastectomy. She was given adjuvant chemotherapy because of the positive lymph node, and she was not a candidate for radiotherapy. And since the tumor was triple positive, no hormonal or endocrine therapy was given. The next case is of a 50-year-old female who presented with left breast lump of 6 months duration. Again, this case was diagnosed by fine needle aspiration, and after that, mastectomy was performed. So on microscopy, the tumor had a nested in-sheaths architecture consisting of mild to moderately pleomorphic cells with irregular nuclear membrane, eosinophilic cytoplasm, and occasional mitosis, and there was also frequent perineural invasion. On immunohistochemistry, the estrogen receptor was positive, progesterone receptor was positive, and HER2 was positive as well. So this case was signed out as invasive ductal carcinoma, no special type, staged PT2, NO, and MX, triple positive. So when we look at the management for this patient, neoadjuvant, she was not, again, a candidate for neoadjuvant therapy. The surgery done was modified radical mastectomy. Adjuvant chemotherapy was given for this patient because of the tumor size, which was more than 1 centimeter. She was not a candidate for radiation therapy. And since the tumor was triple positive, she was given anastrozole with Carcinoma. Our final case is a 35-year-old female presented with a left breast lump of 2 months duration. And again, this diagnosis was also made on by mammography and followed by fine needle aspiration. On microscopy, the tumor showed nested and ductal architecture consisting of highly pleomorphic cells with binucleation and multinucleation, prominent nucleoli, and frequent mitotic activity, including atypical mitotic figures. On immunohistochemistry, the tumor was estrogen receptor negative, progesterone receptor negative, and HER2 positive. So this case was signed out as invasive ductal carcinoma, no special type, staged PT2, N2A, and MX. There were 4 lymph nodes positive, and estrogen receptor and progesterone receptor negative, and HER2 positive. So this patient, again, she was not a candidate for neoadjuvant chemotherapy, so she was not given chemotherapy before the surgery. The surgery performed was modified radical mastectomy. Adjuvant chemotherapy was given because of the tumor size and the positive lymph node status. Radiation was not given, and the treatment, the hormonal or endocrine treatment was a Carcinoma because of the HER2 positive status. So just to summarize, breast cancer is currently a leading cause of morbidity and mortality amongst adult women, and there is a need for nationally adapted guideline to standardize the treatment and provide better care. And there's also a need to improve the status of the healthcare professionals by implementing specialty trainings and increasing the availability of diagnostic and treatment modalities. Thank you for your attention, and here are my references.
Thanks so much, Miran. So if there are any questions for Miran about the presentation of the cases, please ask away. We had 2 questions about Adam, which I answered, but I'll just repeat those here. The first question, are the medicines for targeted treatment precision medicines? And the answer to that is yes. So we want to be very clear that there are a lot of generic medicines for breast cancer that are available on the EML that are not necessarily available in countries. And that is one of our major focuses, to get all of the generic medications for breast cancer that are on the EML to be available in all of our countries. And we'll do that primarily by working with generic manufacturers to get them registered to the markets and to get the pricing down to a local price, and do that in a bundled way related to breast cancer overall. But there are also precision medicines that we're targeting, because those have much higher impact. They have much better treatment outcomes for patients, and we want them to be available even though they're still on patent. And so those would be the ones that we work on the voluntary license approach to try to get them and make them available. So great question. And then the second question is, can you share the list of the countries? And I did share that list in the chat. As I said, it's a dynamic list, meaning that as countries are identified that have challenges with access, there are many countries that are not listed that you might think should be there. but some of them have done a lot of work in access and actually have a lot more access than other countries. So we tried to prioritize by those that had limited access, but that list is dynamic. That's just the countries in Africa that we're focusing on. There are other non-African countries as well. And then Dr. Lukandi from Uganda, hi Robert, how are you? Made a comment that this is a welcome initiative because it doesn't make sense to have diagnosis and not have treatment, and we agree 100%. And so we will be focused on making sure that the treatments are available, especially around breast cancer as our pilot, and see how that goes, and then open that up to other sites as well. Any other questions for Miran about her cases or Ethiopian's breast cancer program or about Adam? All right, well, we're done a little early today. I'll give you back some time. I know it's late in the day for many of you, so we'll just be finished a bit early today. Really exciting. Next week is our cytology Africa calls, and we have Rose Wu that will be speaking, which looks like it's going to be a really exciting talk. So we hope to have all of you there. Also, hi Ali, how are you? Greetings from California, and I hope you guys are safe there in Sudan. There's also, I just want to let everyone know, there's also a course going on right now with Nigeria called Upgrade Oncology Pathology Series, and that is being recorded. And as soon as that course is completed, because it has a space limitation, we will have those recordings available, and we will share them with you. And I hope that those will be a great opportunity for you guys to hear about some current topics. Many of you may be in that course as well. For those of you who are not, when the recordings will be available, and I can share that link with you during our next call. Miran is typing answer. Is Ethiopia able to form HER2 by FISH for equivocal cases? It's a great question, Chamba, and I believe that Miran will answer that. But what's interesting about FISH is that when you look at treatment guidelines, when you only have trastuzumab available, HER2 3+ on immunohistochemistry is probably the only patient you should be treating. The HER2 equivocals are such a very low number of FISH positive. It's really, really small, and it's very expensive to do FISH. And it may, you may try to find the money or take the time to do it if you had it available. By the time you get the result, it won't have any benefit for the patient. So it's really challenging on FISH. However, with the new HER2 low status, where the patients need to be FISH negative if they're 2+ in order to benefit from the treatment, this presents a huge challenge of how we're going to find that group of patients in the population, because the HER2 low number is a larger number of patients than HER2 negative or HER2 positive. So that's a current technical challenge. And I think the breast strat4 cartridge from Cepheid, which we've discussed in this group before, is likely going to have a way to answer that question, but we don't have that answer just yet. So I don't know if Miran, what she said about FISH. Let's see. Miran said, only availability is stains. However, Fusilake is to be sent abroad to perform FISH. Yeah. So and how do you choose which ones to send? It's the probability is so low that it's going to be positive. It's really a difficult conundrum, and we're hoping that we can solve that technically at some point. If there aren't any other questions, I think it looks like there aren't. We'll say thank you to everyone. Appreciate you. Sorry about the time error this morning. Thank you all for showing up. Still, a lot of you showed up, and I appreciate it. And we will send out the invite for next Wednesday by the end of this week, so you can register, and we'll see you all next Wednesday. Thank you so much. Have a great week.